It's always a tough act to follow. When Amar speaks, he takes you to another level. And to come back and speak in this course is really difficult. Now, when you talk of worst case scenario, it could be a difficult case to begin with, but well done at the end. And that's what Amar always does. Or there are some which get complicated on the way, or they start disastrously, you have a lot of complications on the way, or sometimes it could be a hopeless case, but what looks like hopeless case for us may not be a hopeless case for him. Now this patient, well, there was nothing with the cataract except that, you didn't have a proper position to operate. So he was always like this for last several years. So it was difficult to position the operation table to get him. And then even giving a block was a problem. And we had to fix the eye at 12 o'clock and pull the eye down and manage. And then, of course, the surgery went off well. This is a rather simple case. Well, sometimes it's always good to see some simple cases as well when you compare it to the earlier ones. Now, you have such severe subluxation. Doing rexis also becomes a problem. So sometimes you can use your hooks to fix the eye after you have initiated your rexis, or you can use a spatula from the side port to fix the bag because you still want to continue with your rexis. And the mistake is you have not stained. The reason I did not stain is because when you stain in such a case, the stain goes behind and all the visibility is lost. So now after I fixed the eye, I realized that the rexis is small, so I stain because the lens is brought back into position. You can stain at any stage during your surgery if you find it difficult and poor visibility. So after you stain and after the lens is fixed well, you can use microforceps to complete the rexis, because unless your rexis is big enough, your phaco, which otherwise would be a normal phaco, becomes difficult. And here you are comfortably able to complete your rexis. And once it is big enough, doing your phaco isn't really a difficult proposition. And then, depending on how much of your bag is, has lost its zonules, you can always put an endocapsular ring, because the moment you put endocapsular ring, the bag gets stretched and it prevents, phaco causing you that sucking of the bag and causing unnecessary PC rents. At this stage, it becomes a relatively easy case to proceed with. Then, depending on the extent and comfort, you can fix the bag and put a lens. This was another case with a capsular fibrosis. I decided to use an eye ring to keep the pupil dilated, because I was expecting this nucleus to be hard. And we have several pupil expanders. Pupil eye ring is one of them, and it can be easily placed in. And because the rexis capsule was very much fibrous, I had to use RF capsulotomy to complete it. At this stage, I realized that the eye ring, because it's little bulky, it was almost coming and touching the endothelium. And I felt very uncomfortable continuing with the phaco. So I decided to get it out and go back to my favorite, which is BHEX. At this stage, I get the ring out. And BHEX is placed in. BHEX is a very easy one to place and get it out. And the moment your pupil is well stretched, phaco becomes relatively an easy procedure. this was, I'm just rushing through for want of time because I already have a thing saying time is out. So that's the reason I'm just trying to, this patient was extremely uncooperative to begin with, somehow managed to get the rhexis, and even getting each piece out was difficult. And I was guessing that something is going to happen. Sometimes you should never guess. At this stage, when I'm almost on the last piece, and I say, the moment it's done, it's going to be over, and the nucleus decides to go down. Now, at this stage, if Amar was there in my place, he would be more comfortably placed because he's also a rectal surgeon. So I decide, first what I do is I inject a lot of viscoelastic from anterior, and then from the posterior with the spatula, I try and do posterior, levitation. And with that levitation, assisted by another instrument from your side port, you try and get your nucleus into the remnant of nuclear fragment into the AC. It's sitting comfortably on your rhexis. And of course, this has been nicely shown by Amar, so I don't want to waste much time on that. But suffice it to say that once your phaco is comfortably done on top of the lens, you can always keep that lens into the sulcus, and you would still have a lot of cortex behind and disturbed vitreous. So you go back from, first you just check how much of vitreous you have in the AC, and then you go from pars plana with the cutter, because when you have vitreous disturbance, it's always safer to go from pars plana. In this case, what I really wanted to highlight is when you have such a hyper-mature intumescent cataract, the bag is tense, it's all liquefied cortex. It's sometimes difficult because even the capsule is fibrous. So I thought, and probably that was a mistake, I thought of going with the RF capsulotomy needle. It did do its job, but at one place it wasn't continuous, and when you don't have a continuity in your rhexis, it can always cause you problem. So if possible, with the forceps, you go to those edges. And the best tip here is it's always better to have ECR in the bag, because it keeps the bag stretched and you are comfortable doing your phaco. These are the nuclei which are hardest, but they split well if you get a good hold on those nuclei. So with high vacuum, you try to get a good purchase on the nucleus and split them into multiple pieces. And in between, to be on a safer side, you inject some viscoelastic into the bag. And at any stage, if you notice a tear in the capsular rhexis, in this case I was expecting one, but somehow I managed to get the nucleus out safely and have the lens inside. So these were some of the cases that I thought I would share with you. I would like to thank Amar for giving this opportunity, but for want of time, we have to rush through these cases. I'm sorry about it.